Good afternoon or good morning, depending on where you are, and welcome to our PFF Disease Education webinar series. Today, we are having a session we're entitling Ask a Doc, and we're having members of our PFF medical team to answer your questions that you submitted with your registration. And I will be one of those folks. I would also like to welcome my colleagues, Dr. Sonye Danoff and Dr. Joyce Lee. Before we get started, we have a lot to talk about, but I do want to mention before we get started that our slides are available for download in the participants dashboard in the handout section. So if you'll look to the side of your screen, there's a little arrow pointing to handouts, and you can download our slide deck there. You are able to submit questions through that same sidebar there. There's an arrow that says questions, and you can type in questions. We will try to answer as many as we can today, but we have chosen questions from your submitted queries to go through, and if we can include any others, we will be happy to do so. We did receive some questions specific to some of our listeners' treatment plans or specific conditions, and we are not able to offer specific medical specific medical advice or opinions to you at this time as an organization. But we will follow up with those folks who have unanswered questions after the session. And if you don't mind, please, at the end of our session today, if you'll stay on, there will be a survey that pops up at the end of our webinar. We have in the past sent email surveys, but we are doing an immediate survey after the session today. So if you could stay just a few seconds to a minute longer and give us some feedback about the session today, we would love to hear from you about our series. So without further ado, we are going to get started. Again, this is informational and not intended to be a substitute for professional and personal medical advice. So if there's something specific about your condition you have questions about, we would refer you to your doctor. So again, I welcome Sonye and Joyce. Do you guys quickly just want to give us a brief introduction to who you are and what you do with the PFF?
So I'm Sonye Danoff. I'm a pulmonologist from Johns Hopkins, and I serve as a senior medical advisor for the Pulmonary Fibrosis Foundation Care Center Network.
Hi, I'm Joyce Lee. I am a pulmonologist at the University of Colorado, and I'm also a senior medical advisor to the PFF centered around healthcare quality and research.
And I am based in Atlanta at Piedmont Healthcare, for those who I've not spoken to before, and I work primarily on education and awareness for the PFF. So we are going to jump right in and talk about some symptoms. One of our questions was what causes dry cough and what can be done to stop it. Cough is one of our most common complaints with pulmonary fibrosis, one of the earliest symptoms that people have. And this is intentionally a little bit of a busy diagram, but I will simplify some of these things for you by saying that while people with pulmonary fibrosis often have normal triggers for cough, meaning they might cough for some similar reasons to other people who don't have pulmonary fibrosis, they are much more sensitive to those triggers with pulmonary fibrosis. And there are specific triggers in pulmonary fibrosis lungs, such as changes to the mucus clearance and airways, and the stiffness of the lungs themselves, and the fibrotic changes that then feed back via nerves to the brain and the brainstem and cause people to cough. So there's a lot of factors that that cause people to cough. Some of the most common non-pulmonary fibrosis reasons for cough, which are also present in a lot of pulmonary fibrosis patients, will include postnasal drip, gastroesophageal reflux, allergies in the environment, certain medications that that people take, and potentially even concomitant or undiagnosed asthma. So thinking about these things when I'm in my clinic, I talk about and ask about whether or not symptoms or signs of these things could be present and exacerbating the cough of pulmonary fibrosis. When we talk about management, certainly treating any other causes that can trigger cough. Remember, a lot of the causes are very similar, and patients with PF are just more sensitive to that cough. So treating those other causes becomes really important to decreasing the triggers. And then real non-specific types of therapies with cough suppressants, and sometimes medications like steroids or gabapentin, and opiates can decrease the actual cough itself. So this is pretty general, but I'll ask Sonye or Joyce, any thoughts on these approaches? Is this sort of your take?
I absolutely agree with you, Amy.
All right. We will move to our next question. Why do some patients experience rapid weight loss? Sonye, you want to talk a little bit about weight loss in patients with chronic pulmonary problems?
Sure, absolutely. I think that there can be concerns on both ends of the spectrum for people who find that because they maybe feel less active, that they gain weight. But the other side of that is some people find that they lose a lot of weight after they're diagnosed with pulmonary fibrosis or interstitial lung disease. And the reason for that is really multifactorial, as shown in this very nice graphic. And it probably has to do with a number of different things. One of them is that often the body is really using more energy to accomplish what it would be doing normally. And that's because as the amount of oxygen in the tissues goes down, the ability to burn fuel to allow you to walk or do activities, it becomes less efficient. And so it takes more energy to achieve the same outcome. The other thing that can happen, unfortunately, is also that some of the medications that we use can lead to decreases in appetite or just other GI symptoms, maybe some nausea, maybe some diarrhea, and that can also contribute to weight loss. And I think that one of the things that we often will talk to our patients about is thinking about how to counteract this weight loss by very mindful eating, by trying to pack all the calories they can into what they're eating, adding foods that are very calorie dense like seeds and nuts, whole fat milk products, things like avocados that have very high fat contents of a really healthy fat. And also, we try to remind people to be active because part of where that weight is coming from is the loss of muscle. And so inactivity can cause muscles to get smaller, and being active can help build those muscles back up. So those are kind of my take on thinking about the weight loss that can go along with this. I don't know whether Joyce or Amy wanted to add anything to those comments.
I think that's a great overview. I would also say that, when my patients are losing weight, I do, want to sort of look outside of just the pulmonary disease and make sure we've done things like age-appropriate cancer screenings, looking at medications and things like that to see what might be might otherwise be affecting them and their ability to maintain their weight.
I completely agree with that. And I think, looking for unmet oxygen needs is one of those drivers as part of that process as well.
Really good point. All right, great. Next question. What can I do to increase my oxygen level? Joyce, you want to tackle this one?
Sure. So as some of you or many of you know, the the physiology or the pathophysiology of pulmonary fibrosis prevents oxygen from coming out here and down into the bloodstream. And ways to increase the oxygen level is to obviously provide supplemental oxygen. So if you qualify for oxygen, wearing your supplemental oxygen when it's prescribed can increase those oxygen levels. If you're in a situation where your oxygen level is low and you don't have access to supplemental oxygen, there are things that you can do to try and bring up those oxygen levels. Certainly, decreasing your energy consumption is good. So if you're walking and your oxygen level is low, you should stop and rest. Slowing your breathing and trying to feel, which is hard, feel less anxious about the breathlessness that you might be experiencing. But that anxiety level can promote a type of breathing that makes it less efficient for the lungs to bring in oxygen into the bloodstream. So I think that, the first and the easiest way to increase your oxygen levels is obviously by wearing your oxygen as it is prescribed. And then there are other things that you can do if you're in a situation where you don't have access to oxygen to try and improve those oxygen levels. I don't know if there were other things that Amy or Sonia you thought could add to that discussion.
I think those are really good points. I have a question for you guys that we didn't necessarily have submitted, but it's sort of a current event. And get your thoughts and comments. The FDA put a sort of a public statement out this week, just reminding everybody that our over-the-counter pulse oximeters are not necessarily FDA approved for monitoring oxygen and lung disease. There are FDA approved devices, but they are by prescription only, can be a lot more expensive and are not generally covered by Medicare, intermittently by other types of insurance. And so I wanted to get your thoughts on how we should counsel folks who are seeing this, maybe didn't necessarily know that that was the case, and do rely on their home sort of over-the-counter pulse oximeters from the drugstore, from from online sources and things like that. Have thoughts on this?
I think that one of the tools that our patients have is the capacity to monitor their oxygen. And some people use the portable pulse oximeters that fit over the finger. Some people use smart watches. And I think that the key is to understand that that really gives you an idea. It doesn't necessarily tell you the exact number. I certainly have a lot of patients who will come in and actually compare their home devices to our devices in clinic just to see if they're, calibrated the same. But the bottom line is that if the numbers are going down consistently, say into the low 80s, that's probably a sign that you need more oxygen. And whether the number is exactly 82 or 83 makes less difference than the fact that it's getting below 90. And so using it as sort of a general guide, and also using it to help yourself figure out how much oxygen you need in order to really be able to exercise at your highest level. So if you feel short of breath, it's always reasonable to check a pulse ox and see whether those numbers look like they're a bit low. Maybe that's trying to tell you that you need to turn your oxygen up. But I agree, I think it's important to recognize that this is not a perfect device, but it is a little bit of a guide.
Those are all really good points.
Yeah.
Oh, I was going to say, I like that. I do tell people also that if they want to come in and just check their device against ours in the clinic that are calibrated by biomedical, that can help just give them an idea of the the variance there, and to also make the point that if the patient is feeling very symptomatic, particularly acutely, but their oxygen saturations are looking okay, but there are other signs of low oxygen levels like blue fingernails or lips or something like that, then we shouldn't ignore the symptoms or signs of just because we have a reassuring pulse oximeter, that maybe that's an indication to be checked either in a clinic setting or more urgently.
Yeah, I completely agree. I mean, I've encouraged our patients to bring in their pulse oximeters to see how they compare to, our medical grade ones. And also, I think there's a lot of patients with pulmonary fibrosis in which those finger pulse oximeters won't be accurate by virtue of some of the nature of things like Raynaud's, or, even when you're active and exercising, the reading may not be as accurate. So, as Sonye mentioned, using it as a data point in addition to other variables, I think is very important, and not just relying on a single piece of information.
Thanks, you guys. So we have another question. If my oxygen saturation is at a recommended level, why do I still feel breathless? And I have to remind my patients, they come in and they say, I'm breathless, but my oxygen level says it's okay. This is even outside of patients that have pulmonary fibrosis, for example. But there are lots of factors that can lead a person to feel dyspneic. And I try to let people know that, the feeling of shortness of breath, or dyspnea is the medical term for that, is almost an imbalance between how much work a person feels like they're doing to breathe and how much breath they actually need for what's happening at the time. So if that is somehow imbalanced, then you can feel breathless. And that can certainly happen with low oxygen levels. But there are other factors, like I said, with pulmonary fibrosis, that can lead to a person feeling short of breath. I give the example that doesn't necessarily apply here, but so you kind of understand, in an asthmatic patient who has a lot of wheezing and airflow obstruction, once the air gets down into the airways, the oxygen levels are just fine. Most of our asthma patients don't have trouble with their oxygen, but the work of breathing to get the air through through the lungs is very difficult, and that leads a person to feel shortness of breath even in spite of normal oxygen levels. The lungs being stiff themselves in pulmonary fibrosis can lead to the feeling of shortness of breath, which is very real. Comorbidities and complications like pulmonary hypertension or high blood pressures in the lungs can lead to shortness of breath even if oxygen levels are okay. And then either being above an ideal weight, or having deconditioning, and as Sonye mentioned, loss of muscle mass, so that the work of doing things is greater because we're less efficient machines, can cause that shortness of breath as well. So lots of inputs, and just because oxygen levels are normal does not mean that a person is not feeling short of breath. That feeling can be very real. I will ask for other comments, Sonye and Joyce, and toss out another question that we have from our audience right now, and that is oxygen harmful to the lungs of people with pulmonary fibrosis?
I just wanted to comment briefly about the question about why, why people feel short of breath. And I think that one of the things we always have to remember is that all the things that can occur regularly to a person can occur to a person who has pulmonary fibrosis. And so, at least once a year, I have somebody who comes in and has told me they're short of breath. And it turns out that the regular thing, which is narrowing of a blood vessel in the heart, is what has happened. And so I always try to remind people that just because they have pulmonary fibrosis, that's not going to be the only reason that could lead to them being short of breath. And so just remembering that all normal things happen, and that when you meet with your doctor, if it doesn't seem like it's pulmonary fibrosis that's the cause, then it means that further investigation is necessary. And I think I'll pass to Joyce the question about whether oxygen harms the lungs.
Thanks. I completely agree with Sonye and Amy, just in terms of shortness of breath. That there's so many different reasons why people can feel shortness of breath with or without pulmonary fibrosis, and thinking about all of those things, especially if the oxygen saturations are normal, are really important. And as for oxygen and pulmonary fibrosis, we don't have any data to suggest that oxygen is harmful for patients who have pulmonary fibrosis. And in fact, if your oxygen levels are low, your lungs will benefit from supplemental oxygen in order to deliver more oxygen to the rest of the body. So while we don't recommend exceeding normal oxygen levels or achieving 100% oxygenation, there is no known harm associated with oxygen.
Well said. We have a question about helping with breathlessness. Does pursed lip breathing technique, do pursed lip breathing techniques help with breathlessness? I think that's pretty variable. It's something that a lot of patients get taught in pulmonary rehabilitation, which we'll talk a little bit more about. And I think that I've had, just anecdotally, some people feel like it does help and others feel like it may not be useful for them. But in general, I think there's little harm to be done by it. And so if it's a technique that you've learned in pulmonary rehab and it does help you to feel better, there's a lot of value in that.
I think what it can do, I completely agree, Amy, in terms of mixed effectiveness in our pulmonary fibrosis patients. Really, I believe that was developed in the COPD patient population. But I think what it does, even in the pulmonary fibrosis population, is to slow down the breathing and to really control the breathing and kind of bring down the level of anxiety. So feeling like you're in control. So there are some benefits, whether or not they're specifically to the physiology of the lung themselves, but just to help the patient kind of slow down the breathing, decrease the metabolic rate that might be required when they're, breathless and breathing at a really high respiratory rate. So that's one of the benefits that I talk to my patients about.
And one of the things that I actually have started to recommend more, I think people are more aware of it after this past year, which has been so unusual, is actually meditation. Because meditation, much like pursed lip breathing, is just a way of being very conscious of the kind of the emotions going on with breathing and being able to kind of rein in those emotions. I think Joyce mentioned that sense of anxiety that sometimes comes along with it. So, again, I think that each person kind of finds the best way of controlling that shortness of breath. But I definitely find that meditation has been very helpful for many of my patients to just know what to do to be in control if they get into a situation of being out of breath.
All right. This is a heavy question. So are there natural remedies or supplements that can be helpful to patients with pulmonary fibrosis? And are there ones that patients should avoid? Joyce, I'm going to pass this one to you.
Thanks. So, I think with the age of the internet, of course, access to all sorts of things on the internet are increasing, and herbal remedies or over-the-counter supplements are one of them. In terms of data for patients with pulmonary fibrosis, there's nothing that we know of from an herbal standpoint that improves lung function or symptoms related to pulmonary fibrosis. I think if you're investigating herbal supplement options, it's really important to discuss those with your doctor and your pharmacist specifically, because there are potential for drug-drug interactions, which we worry about in patients who are on prescription medications. The other thing is, while herbal supplements are monitored by the FDA, they're not monitored to the extent that prescription medicines are. So they don't have to prove benefit or efficacy in the disease state that they're advertising for. So you really do have to take these advertisements with a grain of salt, so to speak. Just make sure that you go into it with a healthy deal of skepticism, discuss any potential treatments with your doctor or your pharmacist before taking it, and then always follow the label in terms of how much to take if you do decide to take an herbal supplement.
And I would just add, I absolutely agree with you. I would just add that when you go to talk to your doctors and you talk about your medications, please be sure to mention the dietary supplements that you're taking, because sometimes people don't see those as being drugs, but they definitely, just as Joyce said, they can have a very potent interaction with the other medications that have been prescribed for you. And so it's really important to make sure your provider is aware if you are taking them.
A really great point. I would also bring up a corollary to that question, and that is, are there diets or foods that help with pulmonary fibrosis? My general answer to that is to recommend really a balanced, heart-healthy type diet. Cardiac disease in particular is a common comorbidity or common coexisting problem with patients with pulmonary fibrosis. But I think most of us would benefit from some form of just a balanced and heart-healthy diet, whatever flavor really floats your boat, be it vegetarian, vegan, Mediterranean, or whatever. And I think these types of extreme diets, I tend not to recommend. Any comments on that, Joyce or Sonye?
I completely agree. I think the extremes of anything is bad for anybody, whether or not you have pulmonary fibrosis or not. And that's exactly what I recommend to my patients, is a balanced diet that's heart healthy. And sometimes, for our medicines, we do need to think of some dietary strategies to help improve the tolerance of the medication. But even then, it's still a balance of nutrients, which I think is important.
I think that, just as it would apply to dietary supplements, there isn't a magic answer, and doing what seems reasonable is generally the right thing to do. If there were some diet that really were magically going to make this better, I don't think it would be hidden. I think we would talk about it. And so really what we're just saying is do what makes sense in terms of your health in general, and that will also improve your health related to your pulmonary fibrosis.
Completely agree. I would echo what Joyce said about the supplements in terms of a healthy dose of skepticism. If somebody is advertising a diet that would cure or help specifically pulmonary fibrosis, eliminating all of one element from one's diet has never been shown to cure. Well, I won't say never, but hasn't been shown to cure respiratory disease that I'm aware of. And so, all green smoothie diets or what have you, again, healthy dose of skepticism and making sure that we're not getting away from a balanced and sensible type of diet. All right, moving on to some treatment and management options. We had a great question. When should a patient consider palliative care? Sonye, you want to talk a little bit about, first of all, what that means for our audience here and sort of address the question?
Absolutely. I think this is such an important topic. When we talk about treatment for a disease, we often talk about treatment which is targeted at the disease itself, so disease modifying therapy. But when a person has a disease, whether it be pulmonary fibrosis or many other types, they also can have symptoms that are related to the disease. So we just spent a while talking about shortness of breath and about weight loss, and these are all symptoms that go along with pulmonary fibrosis. But we can treat those symptoms directly. And obviously we do that because if a patient tells us that they have a cough, we try to figure out what to do to make the cough better. If a patient has shortness of breath, we try to figure out how to make the shortness of breath better. But there's really sort of a more global approach to the idea that there are many things in medicine that we can't fix, but that we can help people live their lives in a better way. And the word that has been applied to that is palliative care. But I would also say it's just really it's self-management. It's recognizing that there are symptoms and some things we can fix and some things we can just make better. And so there's been a lot of discussion about when palliative care, the symptom management, should be brought into the care of our patients with pulmonary fibrosis. And I think that we probably would all agree that it should start on day one, because the first thing that we want for our patients in addition to being able to give them a diagnosis and, typically a disease-directed therapy, is we want to know what symptoms are troubling them. What are the things that are taking away from their quality of life? And we want to address those in the same way we would address the illness itself. And so palliative care really runs alongside all of the care we give, and it is just that care which is focused on living the best life for the longest time and addressing the symptoms that take away from that quality of life. I don't know whether either of you want to add on to that. I know that you've both been very engaged with palliative care with your own patients.
I think that's really well said. And I would also make the distinction for those people who haven't heard some of this terminology frequently, is that, palliative care is oftentimes thought of as synonymous with hospice care, but it really isn't. You think about an umbrella term of palliative care, meaning supportive and symptom-based therapies and care. Hospice is just a small subset of that takes place at the end of life. It's not a place, it's not necessarily one specific thing, but those are different parts of a spectrum, sort of an umbrella term in a more specific time frame. And just because somebody is talking about palliative or supportive types of care, it doesn't mean, this is the end, this is over, I should, my doctor's given up on me. I think personally it's a very thoughtful approach to management of patients to help them feel better while while disease-focused care is taking place as well.
Yeah, I completely agree. I mean, I think they're great partners in helping those with heavy symptom burden, or even not even heavy symptom burdens, or symptom burdens that can improve the quality of life. They're really wonderful partners to engage in long before we're even thinking about hospice and things like that. So I think separating those terms is really critical as you think about whether or not to engage palliative care as part of your disease management strategy.
Oh, great point. Thanks, Sonye and Joyce. So this sort of dovetails with what we were just talking about, but what can I expect in general as the disease progresses? Joyce, want to tackle this one for us?
Sure. So, of course, as the disease progresses, symptoms of breathlessness are probably the ones that we think of primarily. However, as this figure points out, that it's not just shortness of breath that we have to keep in mind. Things related to cough can progress, other symptoms outside the lungs, a general feeling of fatigue. Of course, anxiety and depression are ones that are not infrequent as the disease progresses, and so talking to your provider about that. And of course, all of these things contribute to how the patient feels, and so this quality of life, or the feelings that we have as a result of these medical conditions, are the ones that are impacted pretty substantially. So these are things that, some of these are symptoms, dovetailing into the last conversation, that palliative care can help with, but also, looking for other things along the way. And of course, having pulmonary fibrosis puts you at risk for other things down the line. And so just being aware that pulmonary hypertension, which is that high blood pressure going to the lungs, increasing needs for oxygen, can be other things that contribute to how you feel as the disease progresses. I don't know if Sonye or Amy have other comments on that one.
I mean, to me, I think the most important part is the very center, which is quality of life. And that's really what we're all about, is doing whatever it takes to achieve the best quality of life for the longest period of time. And that takes addressing all of those things that are in the outside ring. And for each person, it will be different. It's not as if there's a one size fits all. And I think that's a really big part of why we feel it's so important to be really forthright in talking with your provider and really saying, what is it that's bothering me myself, as opposed to the general idea of what happens to patients with pulmonary fibrosis.
a really great point. I'm going to actually, since this is a linked question, move to the next and ask, why does pulmonary fibrosis progress, and why do some people progress faster than others? Sonye, you want to keep on and tackle this a little bit for us? It's a challenging question.
Sure. Yeah, it is. It is. And I think part of what makes this challenging is that we talk about pulmonary fibrosis as being sort of like a one thing, but really pulmonary fibrosis encompasses a bunch of different diseases. And you heard from Joyce the fact that they all tend to affect that very important relationship between the place where the air enters is in the lung and comes near the blood vessels to be absorbed into the bloodstream. But there are many different reasons. And because of that, we can see very variable courses. And so we'll see that there are some patients who, are diagnosed and have a very rapid progression, like is marked with that line A. And then there are some people who are the people who are marked with the line D, where they really go for years and years and years before they ever have a symptom. And then there are also those events that are marked with the stars that are what we call acute exacerbations. And that might be that, somebody gets an infection. Obviously, that's a big part of why we're worried about COVID-19 right now. In previous years, we've worried about our patients getting flu, because those infections can sometimes suddenly change the trajectory of disease. And so a lot of what we do as we meet with our patients is we monitor the progression of the disease. We measure things like breathing tests, and we might look at a CT scan every couple of years. And we talk about what that means in terms of rate of progression. But for every person, this is going to be different. And there are even going to be people who have certain types of interstitial lung disease that might not progress at all. And so, again, being familiar with your pulmonary function testing, talking with your doctors about these kind of trajectory, that's the direction that you're going, and talking to them when you have a problem about whether this might be an acute exacerbation and might be something that tells you that things might get a bit worse. I think those are really important conversations to have and information to keep for yourself. I actually really encourage my patients to keep their pulmonary function tests, because it's sort of a roadmap that allows us to see how things are progressing over time. I don't know whether Amy, or do you and Joyce use other strategies?
I actually really agree with all that you said. I have a very similar approach as to what you described there. Joyce?
No, that's exactly what we do. I think using symptoms, lung function, and sometimes radiology to determine, their past course, and, discussing how it's really challenging for us to predict future trajectories and things like that. But yeah, no additional comments.
We have a really interesting question that sort of ties into time frame that I will give to you guys and get your comments. This is actually a great question about research, actually. And, we're seeing here that the progression of disease is variable, that there are some patients who remain stable for quite some time, and that those on the other end of the spectrum that progress very quickly. But the question here is that there is often a time from diagnosis limit of, sometimes 5 or 6 years for many clinical trials. And that's variable. There's certainly some that are 3, 5, 6, 7. But your thoughts on why that might be, and then whether this ought to change.
That's a great question. And again, those numbers are numbers that the people who are setting up trials want to try to be able to look at patients in a window where maybe the change in their lung disease is going to be the most kind of noticeable. So if there's an effect on the change in lung function by the medication that's being investigated, they'd like to know that in as short a time period as possible. And so, we kind of create these dates like, oh, well, you have to be within 5 years of diagnosis. Well, we know that a lot of diseases, as you can see in this graph, before there are symptoms, the disease probably starts before people recognize it. And so, again, these are sort of just ways that we try to create some order to the way we recruit patients to trials. Sometimes we also use other what are called exclusion criteria, like using what your forced vital capacity is. That's a measure that we get from our breathing tests. And again, it's just to try to make the group as similar to each other as possible, and to be a group that is most reflective of people who would be likely to benefit from an intervention as possible. But I think we would all agree that these numbers are just convenience numbers. It's not like they don't tell us truth in any way.
They're great points. I think I completely agree. The goal of the trial is to enhance the trial population for being able to see whether the intervention, the drug, or what intervention is being studied, see if it's making a difference. And if you have a very largely stable population, which the assumption that's made in creating these rules is that people who have had their diagnosis for a long time, relatively speaking, are potentially those who might be, quote unquote, more stable and may not be able to detect a difference in, a treatment versus a placebo group, for example. There's a question here that sort of ties into that, whether there's a difference between idiopathic pulmonary fibrosis and other types of pulmonary fibrosis in their disease progression. And I think this could get at the idea of progressive fibrotic interstitial lung diseases that are not necessarily IPF. And there are, studies out there that are using not necessarily time from diagnosis, but evidence of progression in these other types of pulmonary fibrosis to determine whether patients should be included in clinical trials. So there may be some model for that. Joyce, thoughts on that?
Yeah, no, it's actually a really great question, and one that's an active area of research and investigation. Certainly, while a lot of the past research has focused largely on IPF, we are recognizing similarities between IPF and other forms of fibrotic disease, and trying to figure out why those similarities exist, whether it's genetics or other reasons for those similarities, I think is an area of active investigation. And then also, in terms of treatment, there are studies that have now investigated these progressive forms of fibrosis and the potential benefit of some medicines in those particular patient populations. So I think this idea of progressive fibrosis is an evolving one for sure. I think it's still very important to make sure you have the right diagnosis. This doesn't, I think, give us the liberty to just dump people into a single diagnostic category. So specific diagnosis remains important, but I think it gives us a lot of leeway in terms of what's in our toolkit when patients progress, and that's really important.
That's great. Thank you. Okay, so now we're getting to, I think we have one more question about progression. What are the stages of pulmonary fibrosis? So this is I didn't have a great graphic for this. I'm going to ask Joyce to talk a little bit about it, though, and how we conceptualize the severity and stages of pulmonary fibrosis.
Yeah, I think for me, I think of it in perhaps four stages. The first is what I think of as an at-risk patient population. So these are patients who are in families with pulmonary fibrosis or have conditions that put them at risk for developing pulmonary fibrosis, like our autoimmune conditions, but they don't have disease, but they are at risk because of their family history or their underlying medical conditions. The next stage that I think of is the early stage, where they are either identified because of early symptoms of dry cough or shortness of breath, or patients also in this category, lung cancer screening studies are identifying interstitial lung disease earlier than they would have presented usually. And so this is the early stage. Most of our patients, I would say, are in the next stage, so the mid-disease stage, where patients have symptoms related to their pulmonary fibrosis and have some impairment in lung function as a result of that. And that's, I think, where the majority of our patients that we see in clinic lie. And then, of course, the last stage, or the later stage of disease, where the disease has progressed, that is the terminal stage of the disease. And that is the way that I generally think of the stages of pulmonary fibrosis. I know that others use FVC, forced vital capacity, or breathing test thresholds for that, and I don't find those to be very useful clinically. I think it really just has to do with the whole patient, how they're feeling, and where they are with their symptoms primarily.
The one thing explanation I've heard in a long time. Sorry to interrupt.
Yeah, that was great.
Go ahead, Sonye.
No, that was great. No, and the only thing I would point out is that, we use the term pulmonary fibrosis in a very broad way. And so Joyce mentioned that there's some people who have autoimmune diseases. And it's also important to recognize that there are a lot of people who develop these interstitial lung diseases, which is another name for pulmonary fibrosis, who actually get better. And the autoimmune group is one of those groups where there are definitely patients who get better as a result of the medications, the therapies that they have. And I think that was part of the reason that Joyce was pointing out, that we don't want people to be just lumped into this notion of being progressive and fibrosing, because some people aren't. Some people will stabilize and some people will get better. And so we really think that the diagnosis, what caused the interstitial lung disease, is really critical as a part of this process of understanding the disease.
Those are very good points. I was really impacted by a piece that Jeff Sligris wrote a few years ago from the patient perspective, thinking about sort of stages or points in time I think he called it touch points and transitions in the life of a pulmonary fibrosis patient who is in that progressive type of category, and using the need for oxygen and as a marker that patients and caregivers can really can feel and see and have to accommodate for in their daily lives. So thinking about it from that perspective has also been sort of a general but clinical way for me to think about that sort of early, middle, and stage type of disease as well. Okay, so we're going to move on. So we did have some COVID-19 questions. I know this is a really hot topic. Imagine that in our community and in our world. And so we did want to have a few questions specific to COVID-19 and pulmonary fibrosis. We do have several posted webinars on our website and our YouTube page that are really specific to aspects of COVID-19. So I would refer you to those if you have a chance to go back and watch them. But so our first question was, should patients with pulmonary fibrosis get vaccinated for COVID-19? And I just was going to take this one because I thought it was a really easy question to answer. Yes, I absolutely would have and do recommend COVID-19 vaccinations for my pulmonary fibrosis patients. There are very few true contraindications to being vaccinated, and those are severe allergies to first doses, for example, or known severe allergy as an anaphylaxis to one of the carriers of the vaccines themselves. But those are pretty uncommon, and when you look at the number of patients who have had the vaccine and who have had actual anaphylactic responses, it's been exceptionally rare, and we're aware of that possibility, and has not resulted in any untoward or serious bad outcomes beyond the reaction itself. So lots of questions specific to whether this is safe in pulmonary fibrosis patients, which I do believe that it is. And then also, let's see, what people will be able to do after they're vaccinated, or recommendations after vaccination. Currently, that looks like pretty much continuing life as pre-vaccine, maybe just with a little bit more confidence. The vaccines that exist that are authorized in the United States right now are very effective at preventing symptomatic and severe disease and hospitalization. So that's it's incredibly good for our community. But there's growing evidence that this is going to help us as a community as well as an individual, meaning that unclear how much transmission will be reduced, but it does seem to be that we'll be less likely to transmit the virus, give it to other people after vaccination. But for now, the recommendation is still face coverings, masking, continued social distancing, although we're anticipating that we'll see additional guidance from the CDC sometime in the near future about what people who have been vaccinated might be able to start to normalize in their environment, particularly around those who have also been vaccinated. But I myself am still wearing a mask anytime I go anywhere, and when I'm not in my office by myself or at home with my family. So I've definitely taken that to heart. Joyce and Sonye, I know the answer to this, but are you guys recommending vaccination for your patients?
100%.
Yeah, I think this is just like one more step in terms of getting us back to normal. It's sort of, the analogy I give is it's like, you put on your seatbelt when you get in your car. You don't do it because you're going to drive your car into a tree. You do it because if by chance you encounter a tree, you want to have your seatbelt and your airbag to help make sure that you walk away from that accident. And so this is like one more piece of safety equipment for our patients to prevent them from having a severe outcome with a COVID-19 infection.
Absolutely. We had another question, and this is a common question. If the vaccine can trigger an exacerbation or the onset of pulmonary fibrosis in people who are at risk or who have a genetic predisposition to pulmonary fibrosis. And what I would like to say about that is that if we're going strictly by the evidence that exists for the vaccine, the COVID-19 vaccines themselves, we don't have the longest term data on this, but I would also go back to what we know about the safety of all kinds of vaccines. And this graphic here is known triggers of pulmonary fibrosis or known risk factors. So acid reflux, genetics, certain medications, smoking, exposures. And what you don't see there is vaccines, not vaccines for respiratory viruses, for bacteria, for any other type thing. It's not on the list. And so one would not think that the COVID-19, just intuitively and scientifically, that they would be in any way different. And so I would have told my patients this information, and also told them that if I were in that situation, I would much rather take my chances with a highly effective vaccine than I would with the virus itself. Sonye or Joyce, any thoughts on that comment?
I mean, I totally agree with you. There's some things that we won't know just because this is such a new disease, but overall, what we know historically suggests that the vaccine should be as safe and effective. And unfortunately, we also know that for patients who have gotten COVID-19 and ended up in hospitals, it's been a very difficult road for them. And unfortunately, we've had a number of patients who have died from this disease. So it's balancing an unknown risk with a known risk.
Yeah, I agree with both of your comments. I think we obviously can't know for sure, but things that we already know about the disease and other vaccines would suggest that it would not be the case.
I would also say that in the United States, you can help with that. It would help with the knowing of those things. So if you are vaccinated in the U.S., there is the VSafe program where you can register and give feedback about any side effects from the vaccine that you may have, and any downstream sequelae that come up. So I registered for this when I was vaccinated, and I after each dose, I had a daily reminder on my smartphone to fill in an anonymized survey that gave feedback about, did my arm hurt, did I have a fever, and so on. And now I got just a weekly check-in to say, how are you doing? Have you been diagnosed with COVID? Are you having any other unexpected or unplanned events? And so there is now a growing body of information about the safety from that VSafe program. And across the board, I think we're learning that these are incredibly safe and highly effective too. So there is that monitoring going on. And if you have been vaccinated, I would encourage you to help us understand that information better, so you can contribute to the knowledge base about this. All right, and our last pre-submitted question is what has happened to patients who have become ill with COVID-19? Sonye, you alluded to this just a moment ago. Can you talk with us just briefly about what we do know about when patients with PF get COVID-19?
Sure. I can talk about sort of our local experience and then what's available as far as research so far. Fortunately, very few of our patients have become infected, and I think it's because our patients have been very well educated about the importance of avoiding infection as one of those triggers of progression of lung disease. And so we've had our patients really be amazingly careful about their interactions. Unfortunately, a few patients have become infected. And what we know is that some of them get fairly severe disease. And after they have the severe disease, they may have more oxygen requirement than they had before they started. There have been a couple of trials there have been a couple of papers that have come out, research papers, looking at the outcome of patients who had interstitial lung disease versus patients who did not. The ones that I'm thinking about most recently was from Europe. And what it showed is that, unfortunately, patients who have pulmonary fibrosis don't do as well if they get infected. And I think that that's not too surprising because COVID principally damages the lung, and we know that pulmonary fibrosis has already caused some damage to the lung. So again, I think these are all the reasons why it's so important for our patients to really stay safe, get vaccinated, and if you have symptoms of COVID-19, to try to be seen, appropriately by a doctor, because there are a lot of new therapies that are available now for patients who do become infected.
That's a great point. We are actually running up against the hour, and I have tried to get it to as many of our submitted questions as we can, but we certainly we're not able to answer all of your questions, and we appreciate all of your engagement. This has been amazing. We'll try to follow up with everybody who had questions after the fact. But I did want to end on one of my favorite topics. Just briefly, we had a great question in the box about what is pulmonary rehabilitation, and is it available during the pandemic? So I'll kick off and say pulmonary rehabilitation is just a fantastic program of prescribed exercise for patients with pulmonary conditions, pulmonary fibrosis included. It's run usually by either respiratory therapy or physical therapists, or both, and includes exercise that is aerobic and also weight building, so light weights and bands, to improve people's functional capacity, quality of life, symptoms, and then also includes oftentimes an educational component to learn a bit more about how to manage lung disease and chronic respiratory illness. It's generally covered by people's insurance for a prescribed number of visits, and then oftentimes patients who will complete that will go on to a next phase type program that has a little less intensive monitoring, or to something like a community program like a Silver Sneakers, or can do things that they've learned. Part of that being educational can translate into, I can take this and do it myself when I'm finished with the program and maintain the gains that I've achieved. With regard to it being available during the pandemic, that sort of depends on where you are and the program that's there in proximity to you. There are some programs that are trying to do some virtual options and making it a little bit more accessible. But many programs now are open with a reduced capacity and appropriate distancing. So if you've not been to pulmonary rehab and you think it might be useful, it's certainly something to talk with your doctor about, potentially get a referral and see what options might be available in your community. So I wanted to end on a high note. Sonye and Joyce, do you like pulmonary rehab as much as I do?
Love it.
It is magic.
It really is. They give people some kind of magical Kool-Aid and they love it when they go. So, well, again, I wanted to thank everybody. Thank you especially to my colleagues, Sonye and Joyce, for being here today. I think this has been a really great session. I'm so glad we've been able to get to so many people's questions and just talk with our community and let our folks see our faces and at least interact in the way that we can. And I'll remind everybody just one more time, please stay as we close the session here and hit up our survey, give us some feedback. And for those who didn't have answered questions, we will try to reach out to you in the next few days. Thank you, everybody, and have a wonderful rest of your day.
Great. Thanks.
Bye, guys.